defect in leukocyte function, right? So now what we are going to do is we are going to scroll up and see all the processes more or less, and from there we will actually talk about the various disorders. Okay, so let's go on to over when we were talking about, suppose, yes, over here. Remember this? These were intravascular cellular changes. We have talked about this, the intravascular cellular changes, wherein there was firstly margination, then there was rolling, then there was adhesion, and then there was the transmigration or diapedesis, right? So when we had talked about rolling, adhesion, we had talked about a couple of very, very important molecules. See, they are written over here. What are they? They were, for example, Cellular X or selectin, and also we had integrins. So what exactly were these molecules doing? If you remember, we had said that the interaction between these molecules expressed on the leukocytes and their complementary molecules or receptors which are expressed on the activated endothelial cells. Their interaction, initially it causes a loose adhesion, which is rolling, and then complete stoppage of firm adhesion, which is due to interaction between the integrin molecules which are expressed on the activated leukocytes and the adhesion molecules which are actually expressed on the activated endothelial cells. So now with that knowledge kind of at the back of your mind, let's talk about what would happen if there was a deficiency in those molecules. So suppose you don't have enough integrin, or you don't have enough Cellular X. What would that lead to? Obviously that would lead to problems, because that is not supposed to happen in a normal inflammatory response. You are supposed to have adequate amounts of all those molecules, but suppose due to some genetic defect those molecules aren't expressed enough, aren't produced enough for a person to have a normal inflammatory response. What would happen then? Then the person will actually, this is the first topic at hand as far as defect in leukocyte functions is concerned, then the person would have what we say to be a couple of disorders, or the person himself or herself wouldn't have those couple of disorders, he or she would have only one of those disorders, but collectively these disorders, they are something which are known as leukocyte adhesion disorders. Obviously is extremely self-explanatory, couldn't have been more obvious. LADs, leukocyte adhesion disorders, because here there is a disorder which is associated with the adhesion of leukocyte. Can be the loose adhesion which is rolling, or can be the firm adhesion which is actual adhesion. Disorders in that, defect in that. So what would, from your common sense, what would happen in that case? What will be the clinical picture of a patient with leukocyte adhesion disorder? Very easy. You have a problem with leukocytes. So what will be the clinical picture? Yes, obviously, very good. The most obvious clinical manifestation is there will be increased, very highly increased incidence of infections. It couldn't have been more obvious than this. Obviously, you have a problem with leukocytes, so a very high incidence of infections. The person would get infected very quickly, would have a harder time to fight off that infection as well. Another problem, another clinical manifestation is neutrophilia. Neutrophilia means that there is very high numbers of neutrophils in the blood. Now, why is this the case? This is also pretty, I would say, self-explanatory, but it's not that obvious as the first point. The reason is, since you have a problem with the adhesion, and since this is a problem which would essentially mean that, in this case, the neutrophils would have a problem to transmigrate to the offending agents which are present outside the blood vessel. Because remember what adhesion was all about? It was a ploy, it was a tactic which was employed by our body to kind of push the leukocytes, to push the neutrophils out of the blood vessel so that they can migrate to the offending agent source which is present out of the blood vessel. But now you cannot do that. So even when there is increased infections, even when the body is kind of responding to that by increasing the production of leukocytes, by increasing the production of neutrophils, there isn't much change as far as the body's infection response is concerned, because those increased number of neutrophils are not able to reach the source of infection. They are trapped within the blood, which would mean neutrophilia. High numbers of neutrophils in the blood. Okay? And another very, very, very important and again very obvious clinical manifestation, which is no pus formation. Pus is actually a very important, and this is something that I don't think I have talked about in the actual inflammation topic videos. Pus is actually kind of a product. It is kind of a, you might say, end product, a byproduct which is formed due to the entire inflammation process taking place. So due to inflammation, as I had mentioned, inflammation is a very taxing process, but the main objective of inflammation is to kill all those offending agents, as bacteria, viruses, parasites, whatever, foreign bodies, to rid them off. And in this process, there is a lot of damage and destruction to the body cells as well, especially the cells which go on to fight these battles, which are the leukocytes. So all these damaged cells, the damaged, you might say, cells and cell debris and dead microbes, together they form a kind of a fluid like exudate, you might say. It's not an exudate actually, it's kind of a fluid like accumulation at the site of inflammation, after which, or rather the formation of which means that the inflammation has taken place. The battles have been fought, these are the dead bodies. Here lie the dead bodies of enemies as well as the soldiers of our body. So that kind of fluid, or that kind of you might say end product, that is actually the pus. Okay, and that is why pus is often white, because yes, white blood cells, they have fought the battles, right? So there is a very high concentration of white blood cells in that. That is why pus is often white. So pus, from this kind of small discussion on pus, what I want you to remember is pus is actually the product of inflammation. Here there is defective inflammation, no inflammation actually taking place. Inflammation cannot progress, cannot advance, so there is no pus formation. Okay? So these are more or less the general manifestations of leukocyte adhesion disorders. But there is a but to this. Depending on what deficiency you have, do you have a defect in integrins or do you have a defect in the selectins, the sialyl Lewis X molecules? Depending on that, leukocyte adhesion disorders are of two types. Okay, pure information. This is completely information. This is not a very obvious thing, or this is not common sense or stuff like that. This is completely information. So one of them is called obviously LAD1 and the other is called LAD2. Okay, LAD1, LAD2. LAD1, 1 in Roman looks like I. So we can say that LAD1 is due to integrin family of molecules defect. Let's actually draw a line here. Okay, so integrin defect, I and kind of I, Roman 1. Okay, now obviously we know that integrins, there are varieties of integrin, because integrin is not just one molecule, it is actually a family of molecules. And in the actual information process, I think CD18 was a very important integrin. LFA is a very important integrin. So defects in them, defects in their formation, that would actually lead to leukocyte adhesion disorder. What type? Type 1. Okay, whereas this one, type 2, 2 means second, S, second, S for Cellular, Lewis, X defect. Okay, so the hints for remembering what causes these defects is in the name itself. LAD1 integrin defect, LAD2 or LAD2 S, Cellular, Lewis, X defect. Okay, so now a little more detail about, just a little, not too much obviously. First thing that you need to remember is LAD1 is a little more severe than LAD2. Okay, little more severe, not too much, it is a little more severe, less. Third point, and this is the most important point. Okay, the most important point, that is, how exactly are you going to differentiate sitting in a clinic as a doctor, as a physician? How are you going to differentiate between a patient having LAD1 and a patient having LAD2? So the clinical manifestations for LAD1 and LAD2 are a little different. Obviously they will have the shared points, shared clinical manifestations of these 3 points, but they themselves will have a few very special markers, very special identifying points. For LAD1 there is only one very specific marker by which you can recognize it immediately. LAD1 is often, since these are genetic defects, so often the targeted patients here, population rather here, are infants. Okay, so in the pediatric group you might say. In LAD1, often it has been seen, the mother describes that during childbirth, if the child has LAD1, it has been seen that there is, let me use another ink here, delayed separation of umbilical cord. Very, very important. If the child has LAD1, it has been seen that during the childbirth there is a delayed separation of umbilical cord, and the reason for that is that separation of umbilical cord would actually mean that there is a local ischemia. Okay, This local ischemia would mean that there is a local inflammatory process going on, local inflammation. This would mean again that all those steps would likely be occurring that we have talked about as far as the inflammation is concerned, and so adhesion would also be occurring, but now there is a defect in integrins. So that would mean due to integrin defect there will be less number of WBCs reaching to that site of inflammation, which in this case is also the site for the local ischemia where the separation is actually happening. Less number of WBCs means the inflammation process would take longer, the ischemia that would actually take longer, and the separation will take longer. Okay, so this is kind of a rough, I think there is more to this. I'll have to kind of see to this a little bit myself, a little more to this, but this is more or less what you actually need to understand here. Okay, that there is a delayed separation of umbilical cord. Now, as far as leukocyte adhesion disorder type 2 is concerned, that is due to Cellular X defect. Again, what are the distinguishing features for this as far as the clinical picture is concerned? For understanding what the distinguishing features for this is, you need to understand how exactly Cellular X is defective or deficient rather in the first place. You see, let me give these in brackets. There is a certain enzyme called fructosyl transferase. Fructosyl, okay, let's use another ink because green is something that I'm using for the clinical manifestation only. So let's use, yeah, blue, why not? Fructosyl transferase. So fructosyl transferase, this is the enzyme which is kind of responsible for Cellular X formation. Now, if there is a deficiency in this enzyme, obviously that would translate to Cellular X molecules being defective or deficient rather. Now, this enzyme fructosyl transferase, this has some other functions as well. That would mean if this is deficient, Cellular X is deficient, but if this is deficient, the other functions are deficient as well, and those other functions will translate to clinical manifestations in Cellular X defect, which is LAD2. So, what are the other functions of fructosyl transferase? One function is actually it's not a very specific function, but it is actually something which is formation of a lot of very important chemical mediators in our body, which would mean that if fructosyl transferase is deficient, the clinical manifestation here is that the patient would have short stature. Okay. The other function of fructosyl transferase, and this is very important, is that it is actually needed the formation of H antigen on RBCs, erythrocytes. What does this mean? See, this short stature, by the way, this is a clinical picture for differentiating between LAD1 and LAD2. But what does H antigen mean? Very quickly, suppose this is an erythrocyte. Okay, erythrocytes, they have an antigen on them. This antigen is H antigen. Okay, H antigen has a few side chains, may or may not have a few side chains. on its side. Okay. There can be two types of side chains on H antigen present on the RBC membrane. If the side chain is, suppose, something called N-acetyl galactosamine, then this entire antigen, H antigen plus the N-acetyl galactosamine side chain, this is called A antigen. A antigen. Okay. Whereas if H antigen does not have N-acetyl galactosamine but rather has galactose side chain, then it is called B antigen. So A antigen means A blood group, B antigen means B blood group. If both of them are present, AB, like in this case, and if none are present, none, that would mean O blood group. However, for all of that to happen, H antigen itself needs to be present, because we are talking about side chains on the H antigen. In all of them, even in O blood group, H antigen is present. But if H antigen, for the formation of H antigen, for its functions, fructosyl transferase is needed. But if H antigen itself is not present, if that is defective, if there is deficiency of H antigen, as occurs in fructosyl transferase deficiency, then we get another blood group, which is extremely rare, very rare. That very rare blood group is another clinical manifestation of leukocyte adhesion disorder type 2, and that is Bombay blood group. Bombay blood group. Okay, very, very important. So Bombay blood group and short stature, these are more or less the manifestations for leukocyte adhesion disorder subtype 2. So this is more or less the clinical picture for these two defects.